Thank you so much, Professor Kshitij Srivastava, for those very kind words. Honorable Vice Chancellor, Professor Sonia Nityanand, Pro Vice Chancellor, Professor Apijit Kaur, Dean Academics, Professor Amita Jain, Head of Department of Neurosurgery, Professor B.K. Ojha, special guests, Dr. B.K. Acharya, Dr. Raghuveer Srivastava, distinguished members of the faculty, there are so many of them, Madam Devika Nag, she was, I don't know ma'am, long time ago when I was doing my residency, Professor Gauri Devi introduced me to him, me to you, and also Manjari also, both of us were introduced to you. It was really an honor that you could come for the oration today. Professor Mazhar Hussain, Professor Piyush Mittal, so many of the senior dignitaries, apologies if I'm missing out somebody. Distinguished members of the audience, it's indeed a great pleasure to be here. The topic I would like to orate upon does seem a bit intriguing, and the oration may be a bit different. But as I speak, hopefully I should be able to convince you regarding the strength of this oration. A sense of apprehension does fill myself when I realize that I now stand upon the shoulders of these two giants, and whether I would be able to justify the oration on whose name I would be delivering today. A few acknowledgements are in order. My humble salutations to this great teacher, Professor B.S. Das, late Professor B.S. Das, who is no more unfortunately, who was my teacher and mentor when I joined my neurosurgery at AIIMS. He was a person of many traits, a wonderful surgeon, a wonderful clinician, a wonderful human being. But there are some sentences which stand out, particularly the one which is written at the bottom, you may not be able to see. And he used to often quote this, about the story about somebody asking a wise man that what should I become when I grow up? And the wise man answering, be a good human being. There is very little competition in this area. I'm forever indebted to these great teachers, Professor P.N. Tandon, Professor A.K. Banerjee, even though I have not been directly trained under Professor Tandon and Professor Banerjee. But I was so fortunate to come out to AIIMS, and then I felt as if I was connected with them forever. And then, of course, I would like to acknowledge Professor Mehta, Professor Sharma, Professor Mahapatra, who have been my, in a technically senior colleagues, but actually they have been my mentors and my teachers. I cannot proceed without acknowledging our department, without whose support much of this work would not have been done. We are now quite big. This is an old photograph. We are now 27 of us. A few words of gratitude to my parents, my wife. She's managed the home front despite a busy schedule, my daughter, for taking care of herself. And of course, I truly believe that there are always divine forces, and I really thank them because whatever you do, whatever you are, there are always divine forces behind you. And with this, there is a small disclaimer that I'm not an expert, but an humble traveler like you. And I'd like to take you in this fascinating journey to find new cheese. And what is this new cheese? A majority of my lecture is based upon this book. It's called Who Moved My Cheese by Dr. Spencer Johnson. May I have a raise of hands on how many of you read this book? Well, thank you, ma'am. That's a bit of a spoiler. I was hoping nobody would have read it, but I see majority of you have not read it. So fundamentally, it's a story about two mice and little people who used to live in a hypothetical cheese station C. So every day they would come to the cheese station by 9 a.m., they would eat cheese, gossip, do their work, and then go back by 5 p.m. And soon they started thinking this would go on forever. And it's starting to sound very familiar, isn't it? And each of them had a different personality. So we had a person called Hem, who didn't like any changes. So whenever there used to be any change, he used to say, it's not fair, I don't like any changes, I want everything to be absolutely constant. And then there was another person called Haw, who was startled by change initially, but then he used to kind of become flexible, accept it, and finally go ahead with the change. And then we had these two unique characters who were actually mice, Sniff and Scurry, who would, in a split second, go ahead and embrace the change. So they would not be afraid of any kind of change. So one day, the cheese runs out in the cheese station. What happens now? Sniff and Scurry don't even hesitate. They immediately move out of the cheese station. They immediately run ahead and they say, there's no use waiting here, there's no cheese here. We're going to search for new cheese. Haw is afraid. He stays for some time. He says, should I go, should I not, should I go, should I not? And then he finally says, I have to go, let me go. Hem says, no, I'm going to stay back. It's not fair. I'm going to approach the union leader, I'm going to approach the state authorities. The cheese has to come back. It's my right to have cheese back in this tea station. This is a story about how. So each of us have some element of all these personalities within us, but at some point we embrace change and we move forward, because change is the only constant thing which happens in our life, whether it's professional, personal, everything is changing all the time. And I do also feel somewhat similar to how. Yes, we are all apprehensive about changes, but when they happen, when we embrace it finally, we really feel good. And this is an example of a carpal tunnel syndrome, endoscopic carpal tunnel set, which I developed more than 25 years ago when I joined at AIIMS. And I used to do a lot of carpal tunnels at that time. It was a disposable, low-cost endoscopic carpal tunnel set. And this is how it used to look like. I still have it. I still do carpal tunnels with it. We did more than 500 cases, published a paper. I said I should patent it, so we went ahead and patented it. We even got it commercialized. It's available in the market, but it never picked up because there are other kinds of instruments, similar instruments available, and it's not a very common. Nobody actually likes to do, nobody is so much used to this. But it taught me very important lessons. It taught me that intellectual property rights are as tangible as real property. It gave me an essence to what it is to go into innovation, and I enjoyed the process thoroughly. And then I realized that if you need to implement something new, you have to do it as fast as possible, either in form of a patent or a paper. Otherwise, the idea gets stolen from you. So what happens to Haw? Haw comes to a cheese station E, which was empty, but he finds some crumbs of cheese over there. He eats it. He finds it very delicious. And then he scribbles something on the wall. And the reason he scribbles on the wall is for his friend, him, to come later and take these clues and also follow him, hopefully, to a cheese station where there would be more of cheese. And he writes there. The quicker you let go of old cheese, the sooner you will find new cheese. Having cheese makes you happy. So Haw moves further on. Now, I've been doing craniovertebral junction surgeries since 1998. Since the time I joined at AIIMS, I was trained by Dr. B.S. Das. And I've done more than 1,400 cases. And we used to do these massive, severe, complex cases, transoral, posterior fixations. And then we had a revolution by Professor Atul Goyal, who described the distraction technique. And this is the old cheese. We would do a transoral. And I was very proud of this, done 15 years, I think more than 20 years ago. And if I would have done it today, I would feel ashamed of myself. And this is what we used to do earlier. And that's what, based upon Dr. Goyal's technique, we furthered it. We created two motions, and we described the technique of DCR. I presented it in great details yesterday. We published a bunch of papers, more than 30 papers in neurosurgery. And then this was a landmark paper in neurosurgery, which was the editor's choice. And then again, in a lot of other journals, we gave a new hypothesis. We found that 80% of the patients in our country have mutations on FV1 gene. And we gave a hypothesis that most of these patients have weak ligaments and sloping joints. And that's the reason they develop bacillar invagination. And some more paper. So we are now in the process of developing this universal reducer. We developed a new implant system. I could demonstrate the new implant system yesterday. And these are the profile of cases which could be corrected by this technique. You could have severe AAD and they could be easily corrected using this technique. And again, you can see how this universal system could be fixed here and then reduced completely. And again, you can see a very severe AAD with BI and absolutely non-existent cord, again corrected using this technique. So the old cheese was a transoral excision and posterior fixation, but the new cheese is to consider CV junction like a deformity. And the purpose is not only to decompress the spinal cord, but also to reduce the deformity and also to realign the spinal cord. So what happened to Haw? Haw wondered at some point of time, he was overwhelmed by doubt. He wondered, did I make a mistake coming out of the cheese? Maybe the cheese will come back. Maybe I should have stayed back with him. And he was wondering whether he should go back. But then finally he decided to move in a new direction and he felt good. And he wrote something on the wall for his friend Hem. Movement in a new direction helps you to find new cheese. So I have been associated with epilepsy thanks to my wife Manjari. We have started a very successful epilepsy surgery program for the past 23 years. It was mentored by Professor Satish Jain and then Professor Manvir Bhatia, and then we took over. And we used to do hemispherectomies, which used to be highly, it's a very effective procedure. And it is done for children who have drug-resistant epilepsy arising from the whole hemisphere. And it's one of the most effective surgeries. It has almost a 90% success rate. But the fact is the surgery is highly invasive. It's maximally invasive and highly morbid because it's usually done in kids who are 4 or 5 years old, and you need to physically remove one whole hemisphere. And then we thought this is not right. You have kids, and then how can you do such a major surgery? And that's when we started thinking of whether we can introduce an endoscopic technique to reduce. And we worked upon cadavers. We worked upon this for almost 10 years. And then for the first time in the world, we developed an endoscopic technique through an opening of just 3 into 4 centimeters. So this was published in Neurosurgery. I put the scale on purpose because it shows made in India on the scale. So this is a made in India technique. And we published, thank you. We published a bunch of papers, more than 20 or 30 papers, including the highest impact factors, and it came into textbooks, including the textbook of epilepsy by Professor Pete Engel, which is considered as a Bible for epilepsy. And now it's been practiced in several centers across the world. Just to show the example of the minimally invasive nature of this technique, this is a left hemispheric cortical dysplasia, and you can see this fine disconnection of the hemisphere. So we disconnect the hemispheres, we do not remove the hemispheres physically anymore. This was a patient I operated in Malaysia, again having a very severe anomaly called as hemimegalencephaly. Endoscopically done, patient lost only 40 cc of blood. She was having more than 200 seizures a day, became totally seizure free. And these are some of the papers which we published. And based on this, we created another new technique for the first time. We described an endoscopic technique for division of corpus callosum along with commissurotomy. So the use of endoscope along with commissural sectioning was used for the first time for a condition called as Lennox-Gastaut syndrome. It's a very severe condition. The child has as many as hundreds of drops per day. So the parents put the child on a helmet, and the child keeps on having repeated falls and injures himself or herself. And using this technique, we were able to provide 100% relief of drop attacks and about 50 to 60% relief of other seizures. Just to show this is a child of a mother, very young mother. She was hardly 19, who came from the war-torn Yemen. Her husband was killed in war, her whole family was killed in war, and her child was having hundreds of seizures a day. She came to India, she was going around to Mumbai, to Bangalore, and finally she came to Delhi, and we did this technique, the endoscopic division of corpus callosum with commissurotomy, and the child became seizure-free. And because of her very unique aspect of her coming to India and all that, it was published in papers, not for the surgical technique, but how she managed to survive and come to India. And now it's been followed up in a lot of other publications are coming up, and it's being followed up in various places. Now Lamb Sandy is doing it very aggressively. So this is how it is done. We use an endoscope, we retract the hemisphere, we go into the interhemispheric fissure, we identify the corpus callosum, we start dividing the corpus callosum, go up to the splenium, we enter the ventricle to the Kgmu. These are the A2s. Apologies if I'm running it a bit fast. Then we start the anterior disconnection, go right up to the skull base, and then go laterally to the caudate head, thalamus and basal nucleus. Again go down up to the skull base, and then finally finish with the posterior disconnection. So through an opening of just 3 into 4 centimeters using an endoscope, it's possible for you to disconnect the entire hemisphere. We presented this at the plenary session of AIIMS, and it provided a new hope for children. And then, of course, it came into the chapter of by John Stern. He's a director of Epilepsy Center at UCLA, a very good friend of mine. And then he came for this workshop in Banaras, and we went together for having this famous Banaras chart. And during that time, I was asking him, because I was thinking of a new idea, and asked him that, John, do you think it's possible to create a bloodless surgery for hemispherotomy without losing a single drop of blood? And John already knew about my endoscopic technique. So he said, okay, bloodless, maybe you will use a thinner endoscope. At that point, I realized that old beliefs do not lead you to new cheese. If you need to create something new, you have to think in a totally diametrically opposite new direction. And then we did it. We created the world's first bloodless hemispherotomy. And how did we do it? We used this robotic system, we used multiple electrodes, and we created an hemispheric radiofrequency ablative disconnection. So you can see this disconnection. This disconnection is produced by radiofrequency ablation. And it came out in papers also because it was quite a revolutionary technique and came on the cover page of JNS. And for me professionally, it was like moving from an era where we used to produce a hole in the brain to just a line in the brain where you don't lose any blood. We call this a ROCH. So this is how it is done. We put multiple electrodes, provide an hemispheric disconnection. You can see the hemispheric disconnection here. And we do it through multiple holes, twist drills, and we just put sutures. So, and again, another patient who was operated at 6 months, you can see once the sutures are removed, you can't even make out where the surgery was done. In fact, the GP who referred this patient, he called us up. He says, Doctor Sahab, bataiye kya operation kiya? Hame to kuch dikhai nahi de raha operation. And again, you can see this beautiful hemispheric disconnection. We have done, now this has become the sole procedure of choice in our institute. We have done it in more than 25 cases. And this is how we do. We fix it to a robotic system. We make a twist drill. We calculate the target. We put an electrode, start the radiofrequency ablation. We calculate the impedance so that we know where we are exactly in the target. I'll mute it. And then we also fuse it with CT scan and MRI to ensure that we are exactly on the target. And I'll just come to the end when I am removing it. I just want to show you that when I remove the electrode, of course we put in electrodes multiple places and we have multiple markings, so we go on serially burning it. It requires about 100 burns. So when we remove it and we inject glue so that there's no CSF leak, and you'll find that there is actually not a drop of blood coming out. So for sake of modesty in the papers, we mentioned less than 5 ml. But the fact is, there is absolutely no blood loss. And we just put a single suture. We then tackled this very complex pathology called hypothalamic hamartoma, where you have this hamartomous lesion in the base of hypothalamus, and the children present with gelastic epilepsy. So they keep on laughing. It's mirthless laughter. So that's not genuine laughter. It's actually epilepsy. It's form of an epilepsy for the undergrads sitting at the back. So the options which are available are either open surgery or gamma knife. None of them are very effective. So again, we created a robotic technique for radiofrequency ablation, again for the first time. And you can see that what we do is basically we disconnect this hamartoma from rest of the brain using this robotic technique. And this is a published work on hypothalamic hamartomas. So what happens to Hav? Hav was very afraid of new corridors, but he overcomes his fear and then he plunged into the corridor. There was enough cheese in the corridor to keep him going. And he realized something at this point of time and writes it down for his friend Hem. It is safer to search in the maze than to remain in a cheeseless situation. So we go ahead in our journey. We devised a new retractor for endoscopic pituitary surgery. I always felt most of the instruments provided by the companies are not required. And I was also not in favor of this bimanual technique because it's not minimally invasive. You can end up producing severe atrophic rhinitis. And then we devised this retractor, which I called as Easy Track. And you can introduce this retractor in the submucosal plane. So you just retract the mucosa on one side and go transseptally. And the surgery carries on like the usual surgery. You access the sella, you remove it, you open the sella, you start removing the pituitary tumor. And in the end, once we remove the retractor, we just suture up the mucosa. So we don't have to put any nasal tamponades. We just put a stitch on the mucosa and that is it. And this is the kind of tumors you can remove. Large cranial, we had to stage it, but we removed it completely. That was a small unofficial function in one of the conferences in Jabalpur where we inaugurated. And then we went ahead and did something for vertebral hemangiomas. So vertebral hemangiomas are treacherous tumors. They can bleed. If you touch them, they can bleed. And the treatment available is you can do embolization, which can cost significant. It cost a few lakh rupees. And then we introduced a technique of absolute alcohol embolization with short segment fixation. So you can see we injected alcohol in this patient, severe compression, and after that you can see the compression is completely removed. It's a cure. And we published the following papers. We published more than 10 papers now. I'm showing the most seminal papers. And it costs less than $2. It's hardly 40 or 50 rupees. So we have reduced the cost. And this was a lady who was wife of a reporter who was 7 months pregnant. She was paraplegic, had a vertebral hemangioma, and we cured her. We gave her absolute alcohol injection. She started walking. She came walking. And her husband was very, very fascinated. He was fascinated by not because she started walking, but by the fact that alcohol can actually cure tumors. So he was asking us, Dr. Sahab, agar hum alcohol piye to tumor theek ho jayega. But anyway, he published this in the paper. So what happens to How? How found the darkest corridor and he felt afraid. But yet, when he took the plunge, he felt afraid. He also realized something and wrote on the wall. When you stop being afraid, you feel good. And this was my darkest corner. To get into a realm for which I was not used to, and then to take a project from the Government of India, from Department of Biotechnology. So when we were doing a postdoc in UCLA, I worked under Dr. Gary Mathan, and he was a superb surgeon, but he also had a research lab with him. And I found that most of the surgeons abroad, they could be excellent surgeons, but they have research labs with them. They have research scientists working with them. So I found that the dichotomy, the perceived dichotomy that good surgeons cannot be good researchers, which exists in India, doesn't exist anywhere else in the world. So why should it exist here? And taking Gary's help, we wrote up a project which was 1,000 pages. We gave it to Professor N.K. Bhan, and it was lying for almost 3 years, was reviewed several times, and finally we got the project. And for that, I'm very grateful to Professor N.K. Bhan, Dr. Gary Mathan, even Dr. P.N. Tandon. He was so excited when I told him I want a research lab. He corrected each and every word of that 1,000-page article, and he pursued it. And we have these four verticals. We have a first of magnetoencephalography in India, along with an epilepsy surgery and a neurology unit, with a neurobiology lab, where we have scientists who can put electrodes into individual neuronal cells, which is called as intracellular electrophysiology. So we give live tissues, neuronal tissues, within 15 minutes, and they put into live neurons, and they do recordings of the voltage. Using MEG, it's been done in more than 2,800 cases. We can do it for free or for just 3,000 rupees, and if Dr. Roja can send us cases, we'll be very happy to start their epilepsy program here. And we started using very advanced algorithms in order to detect the networks. And then we started the first SCEG system in India. We have implanted more than 537 electrodes. And we do it for cases which are completely MRI negative. So the localization has to be done by introducing electrodes inside, and we use the robot